Dr. Nunziato, Executive Director of Huddle Up Moms. I am so excited. Thank you so much for joining us for the 2020 Pregnancy and Resource Summit. Today we are joined by Dr. Allison Dorica, who is maternal fetal medicine attending at Creighton Clinic and a professor at Virginia Tech School of Medicine. We are going to be talking about gestational diabetes in pregnancy. Thanks so much if you guys have your questions, I have a number of questions that people have kind of sent us ahead of time, Allison. So I can, if they're not able to get on, I know a lot of people want to go to different sessions, then we can ask them at the end. Okay. But I will let you introduce yourself and kind of take over. I'm going to mute myself, but if you need something, let me know.
Okay, well, thank you, Dr. Nunziato. I am Allison Dorica. I'm one of the faculty members in maternal fetal medicine here at Creighton Clinic. And what I do is I help to take care of patients with high-risk conditions, whether it be maternal conditions or fetal conditions during their pregnancy, along with their general OBGYN doctor. So today we're going to be talking about gestational diabetes in pregnancy. So our objectives are the following. So these are the comments that I think people will say or I've seen on the internet. If it's on the internet, it must be true. So I'm going to debunk myths. I have what again? Defining gestational diabetes. The mystery is solved. So we're going to talk about what the cause of diabetes is. And why did I get gestational diabetes, but my neighbor who drinks only sweet tea didn't? Life is not fair. And we're going to talk about that. I can't drink all of this or I will puke. I hear that from my patients a lot, diagnosing gestational diabetes. And I can't eat cake at my baby shower, treating gestational diabetes. And we're going to talk about the truth behind that. I think that chubby babies' cheeks are cute. Well, so do I. But we're going to talk about the impact of maternal gestational diabetes on the baby's health in utero as well as after birth. I just need to get through the pregnancy and I will not have to worry about this in the blood sugar nonsense anymore. Well, we're going to talk about what the real impact is on maternal health after pregnancy if you've had the diagnosis of gestational diabetes. And help, I cannot get gestational diabetes when I'm pregnant. We're going to talk about ways that we might be able to decrease the risk for developing gestational diabetes as well. So what is this? Let's start with myth or fact. Gestational diabetes. These are comments that I found on the internet, and they are things that I've heard in my office as well. My mom didn't have diabetes when she was pregnant with me, so I won't get it. Well, not completely true. While the risk for gestational diabetes does certainly fall within the category of family history. Lots of patients that don't have any history whatsoever of diabetes in pregnancy, gestational, or otherwise do end up with this diagnosis. If you eat candy and drink soda, you will get diabetes. Now, we've all heard this probably from our parents and our grandparents. That's not exactly true. Gestational diabetes isn't a big deal and it'll go away after the baby's born. Well, that's maybe true from the standpoint of it may go away after the baby's born, but that does not always occur in all moms. And gestational diabetes can be a big deal, and we'll talk about why. My blood sugars are only a little bit high, so that's not a big deal, right? No, not exactly. We want really strict control to have the best outcomes. I'm thin and I eat healthy foods, so I won't get diabetes. Well, if only that were true, but it's actually not. If my baby is too big, I can just have a cesarean section. Well, that is actually true. We can do a cesarean section to get a larger than average baby out safely, but there are a lot of other ramifications that go along with the fact that your baby is big. All women who have gestational diabetes have a big baby. Nope, actually that's not completely true. In some cases, moms actually will have a smaller baby than they should. If I take insulin, I'll have to be on it for the rest of my life, right, doctor? Nope, not exactly. I can eat pretty much whatever I want as long as I take my insulin to bring down my blood sugar afterwards. Nope, not quite exactly right either. So what is gestational diabetes? All right, gestational diabetes is carbohydrate intolerance diagnosed during pregnancy. So you're sitting there thinking, I think my doctor's from another country because I don't understand what she just said to me. You'd be in the majority if that's what you're thinking. So let's just break it down to easy. During your pregnancy, your body isn't processing and using the sugars that you eat in the way that it's supposed to be doing it. This is not the same thing as having diabetes that your friend had in 5th grade who had to eat carrot sticks while the rest of the class got birthday cupcakes. This is also not the same diabetes that your grandfather who has it and he checks his sugar unless he doesn't check his sugar unless he's feeling like it's a little on the high side. It's not the same at all. Why is it happening? So why is this happening to you? Well, pregnancy itself actually increases insulin resistance and it decreases its sensitivity to the insulin that your body already makes. And the effects of placental hormones that are very important in growth of the baby and the well-being of the pregnancy can increase this insulin resistance. So, hey doc, what am I trying to do? What are you trying that again? Okay, let me get it just a little bit clearer, I think. The placenta makes hormones that support the pregnancy. However, on the other side of it, that also makes some patients diabetic. Your body's tissues cannot recognize and use the insulin that you're already making to break down the sugars that you eat. About 6 to 7% of all pregnancies will be affected by some form of diabetes, and up to 90% of those will be gestational diabetes. All right, so the big question, everybody asks me, well, why me? I did everything right. I don't need a lot of sugar, and that's great. That's terrific, but it can affect pretty much anyone. So we have risks that we can modify, and we're going to talk about why that's important later. And we also have risks that we can't modify. We just have to live with them. So risks that you can modify include having elevated triglycerides. So we define that as more than 250,000, more than 250. You also will have an increased risk if you have low HDL cholesterol. So HDL cholesterol is that cholesterol we'd like to be a little bit elevated. It's our healthy cholesterol, if you will, and that when it's low may increase your risk. BMI, your weight and height taken together, and basically the way that the rest of us refer to this is obesity. Are we overweight or not? That increases your risk as well. And a sedentary lifestyle. Now, you probably notice that all of those risks kind of go together. And if you have one, you may have more than one. Risks that we can't modify. It's sort of like you can pick your friends, but you can't pick a family. If you've had prior gestational diabetes, well, you had it. That's how it goes. Now we have an increased risk. Parents with diabetes, prior infant weighing about 9 pounds or more. We call that macrosomic, but about 9 pounds or more at term. Your ethnicity, can't change that. It is what it is, but that may raise your risk. If African American, Latino, Native American, Asian, and Pacific Islanders, they have an increased risk at baseline. Polycystic ovarian syndrome, or oftentimes patients will be running around with the diagnosis of prediabetes. That also raises your risk. Cardiovascular disease and high blood pressure as well. So how do we diagnose this? Well, history or blood tests, that's the big question. We used to test moms only based on history or risk factors. But in doing so, what we found is that we will miss half of the women who really do have gestational diabetes if we're only using historical risk factors alone. So the American College of Obstetrics and Gynecology, or ACOG, has recommended that all women should be screened for gestational diabetes between 24 and 28 weeks of gestation by a laboratory-based method or a lab test. So now the question becomes 1-step or 2-step. Sounds sort of like a country line dance, but it's not. So let's talk about what we're going to do to test. Let's take the glucose challenge. That sounds like a whole lot of fun, right? Well, maybe. So we start out with step 1, and this is that sugary, sweet, really, really sweet drink that maybe some of your friends or relatives have told you about, or maybe you've already taken yourself once before. It comes in various strengths and it comes in various flavors. To break it down, this is like a super, super sweet flat soda. And what you do is you drink that, and you drink it in a certain amount of time, so you don't have a good hour to sip at it. And then you'll wait an hour. And you'll cool your heels and wait there, and then they're going to take your blood, step 3. The step 4 is a pretty important part, and you kind of chuckle about it, but if you are that patient that's got kind of a queasy stomach and you drink down a lot of sweet stuff, you need to work on step 4. Try not to vomit. In some cases, patients do, unfortunately, throw up this particular liquid, and we have to test again. We do probably, if that happens to you, ask your doctor if there's something you can take in advance that might help you a little bit with that. All right, so we're back to 1-step or 2-step. So 1-step testing involves drinking a whole bunch of sweet stuff. It's 75 grams worth of sugar, carbohydrate. And then you get your blood taken over a 2-hour period. Now, it starts out, however, with checking your blood sugar fasting. Can't have your coffee in the morning, can't eat or drink anything, and then you drink that sweet stuff on an empty stomach. It's not always the best. The two-step test instead is where you drink a lesser amount of that or lesser concentration of that stuff, and it's not a fasting test. You wait 1 hour and then they check your blood sugar. If that value is abnormally high, then you do the big test. That's 3 hours of testing. And again, it is fasting. So you show up first thing in the morning and you get your blood taken, a bunch of that liquid, and then they take your blood at 1, 2, and 3 hours. Now, these tests with the 2 hours and the 3 hours, the determination of whether or not you have gestational diabetes would depend upon how many values you have abnormal. All right, so that's easy, right? So everyone wants the one-step test, don't they? I'll take that one. Maybe not. So more women are actually going to be diagnosed as having gestational diabetes by the criteria using the one-step test. And they might not actually benefit from the treatment that we will ask them to do. So maybe we want to change our answer. Maybe we want to consider the two-step instead, because if you pass the 1 hour test, you don't have to take the second step. So just adding in what happens whenever you are diagnosed with gestational diabetes early in the pregnancy. So earlier than that 24 to 28 week window that we talked about, well, you might have undiagnosed type 2 diabetes in that case. So testing in early pregnancy is recommended in women that have risk factors for type 2 diabetes. So patients tell me all the time, well, I would know if I had diabetes, wouldn't I? Actually, probably not. Here's a fun fact. Women make sure that their families get to the doctor's appointments. And we are a lot less diligent about getting to our own doctor's appointments unless we're coughing up a lung or we're pregnant. That's the main time that otherwise young and healthy women will go to the doctor. So management, what do we do to manage it once we've diagnosed it? Blood sugar monitoring is the first thing that we target. We're going to have patients check their blood sugars 4 times a day. You're going to do this as soon as you wake up in the morning. That's going to be your fasting value. That's going to be before you get up and brush your teeth and walk the dog and make school lunches. And then you're going to take your blood sugar, check it again, either 1 hour after each meal, breakfast, lunch, and dinner, or 2 hours after each meal. Standard is usually about 2 hours after, but some patients prefer 1 hour related to their schedule and just maybe their own preference. As long as your doctor knows which one you're using and you're consistent with it so that they're not wondering which one and which cutoffs to use to determine if they're elevated, then you should be fine. We want to maintain blood sugars in pregnancy under specific target values in order to have the best outcomes. And these targets are a fasting of less than 95. And after the meals, if it's going to be at 2 hours, it's going to be less than 120. And if it's 1 hour, it's going to be less than 140. And yes, I know everybody feels like they're a pincushion by the end of doing this in a pregnancy, but it is one of the most important things we can do to have an impact and benefit the pregnancy outcomes. So blood sugar control, what do? How do we control it? So diet, that's the first step. Okay, so we want to maintain the blood sugar values in those target ranges or below those target values, but we want to continue to allow appropriate weight gain. So do not try to lose weight or restrict necessary calories in order to control blood sugar values. Now that seems kind of like a duh statement, I get that, but it's not at all uncommon that once you started doing this, you start checking your blood sugars, that you'll start to restrict what you eat in an effort to try to keep your blood values low so you don't have to go on medication. Please don't do that. It actually can contribute to the baby not growing well enough. So we would like, in general, moms that enter pregnancy with normal body weight to have 30 to 35 kilocalories per kilogram per day. Don't bother to do the math. You can worry about that if you end up with a diagnosis, and a nutritionist will help you. We would ask that you have 3 meals a day. Try to schedule them as close to sort of the same time of day as you possibly can. And maybe you would need to have 2 to 3 snacks built in. Also, moderate exercise is recommended. That can be about 30 minutes per day, potentially. And honestly, probably most of us are getting that just running around in our daily lives. So what if diet isn't enough? Okay, because remember, we're not going to try to live on 1 cheese cube alone for a day just to keep our blood sugars down. That's not going to be healthy for anyone. Well, we have medication that we can use to help to bring down those blood sugars at the times that we need to. So insulin is the preferred medication for blood sugar control in pregnancy, and that's both by ACOG standards and the Society for Maternal Fetal Medicine. So the number one reason why we prefer insulin over other medications to treat diabetes in pregnancy is because we know it will not cross the placenta. What that means is it can't get across to affect the baby in any way. So this is safe for the baby. So when we use insulin to bring down mom's blood sugars, what we can do is we bring down those blood sugars, and then all we pass over to the baby is those healthy blood sugars. So this also allows us to get tight control without much in the way of side effects. And you have a flexible dosing schedule. This is especially important for patients who have an erratic sleep schedule or work schedule, potentially people who work shifts. But overall, it allows us to target the medication, the effect on blood sugars where they're high, and not spread out through an entire day if we don't need that. So the other options that we have include the oral hypoglycemic agents or pills. So you probably know somebody, whether it be a relative or a friend, who has type 2 diabetes. The incidence of that's pretty high in the United States at this point. So you may know that they take pills to control their blood sugars and don't test their blood sugars every day. That's not exactly how we want to approach gestational diabetes. Metformin is a medication that sometimes is used outside of pregnancy as well to control blood sugar. And how it works is it stimulates your body tissues to recognize and use glucose. But you have to take this with meals. Otherwise, you will have even further GI side effects that can happen with this medication. And the side effects can be somewhat unpleasant. We see them at higher doses that we have to use. Metformin does cross the placenta, unlike insulin. And the safety for both mom and baby and pregnancy in general in the short term has been shown to be good. But the long-term safety is not certain. We suspect that it's probably good as well, but we don't have any studies to date that really give us that reassurance that the effect on the baby long-term may not have some kind of implication. Half of the women who start their pregnancy care on metformin when a diagnosis is made will ultimately have to either take insulin or add it to the regimen with metformin in order to control their blood sugars before delivery. So if you think about that, it's a 50-50 shot that you're still probably going to be asked to start insulin. Sometimes it's just easier to start out that way. What other management do we employ if you have a diagnosis of gestational diabetes? Well, we're going to do ultrasounds. This is to make sure the baby's growth and fluid are normal. So we also want to start doing some antenatal testing. That can take forms in various ways. It can be non-stress tests, and that is where they put the little belts on your belly and hook it to the machine, and they watch the baby's heartbeat, heart rate. And based on that rhythm and that tracing, we know if the baby is happy and healthy in there at that time. We also may be checking the amniotic fluid index. Basically, it's AFI. This is how we measure the fluid around the baby to make sure that we don't have too little or too much. That is done by ultrasound. There are other testing methods that may be used, and that's really deferred to your doctor. There's no one best way to test babies for reassurance, for well-being during pregnancy, and not any one in particular for gestational diabetes either. So what do we do if you have diet-controlled gestational diabetes? And you'll hear this referred to as A1 diabetes or A1DM. So in that case, we might wait for spontaneous labor as long as the baby is looking good on testing, as long as mom's blood pressures are controlled, and we can wait to just shy of 41 weeks. So that's going to be nearly a week beyond your due date. Well, if you're on medication, though, for control, that we would call A2 diabetes. And in that particular case, we would plan your delivery at about 39 to 40 weeks. We, at that point, know that we're working harder to help you. You're working harder to help yourself keep your blood sugars controlled. And it does increase risk somewhat. So that's why we choose to say, okay, we're done at about a week before your due date. Most babies are ready to go at that point as well. And you're well into the term interval of pregnancy. So cesarean delivery, that might also be suggested, but for the most part, it's going to be suggested if the baby is quite big, and usually that's going to be somewhere around 9 pounds or more. And again, we call that macrosomic. So it's okay if my baby is chubby, right, doctor? Well, yeah, it's okay if your baby is chubby, and some babies were meant to be on the bigger end of the spectrum, and that's okay. However, if your baby is big simply because it's getting elevated blood sugar passed over, then some of the things we might see in utero include fetal distress. Baby's not happy, baby's not doing well. We may see a need for a preterm delivery. Oftentimes moms that have bigger babies also have a larger amount of fluid around the baby, or amniotic fluid is elevated. We call that polyhydramnios. And if you have that, that increases your risk that you may go into labor early or break your water early. And so if you have that, then oftentimes you end up being delivered before term, which is 37 weeks. So after delivery, there are also some implications to the baby from having exposure to high blood sugar throughout the pregnancy. One is actually low blood sugar. So while the high blood sugar is coming from mom and going to baby, the baby's pancreas is going to rev up and it's going to make a lot of insulin because it has to break that down too. When the baby comes out, it's no longer getting the blood sugar from the mom. And so as a result, the insulin production is way too high and it can drop the blood sugar in the baby to dangerously low levels. In extreme cases, babies can actually have significant complications from that. The babies also may have breathing difficulties. We know that persistent elevated blood sugars above the targets we recommend can actually slow down the rate of maturation for the baby's lungs, even at near term or term. You may see high bilirubin. So the bilirubin is what they test for, and you may have seen or heard of babies kind of sunbathing or having little glasses on and they're under the sun lamps. That's designed to bring down the bilirubin levels. You also may see an increase in need for NICU care. After you've gone through all of this struggle, you've gone through all of the time that you put into checking your blood sugars and making sure they're eating healthy, you want to make sure that you can take that baby home and not leave the baby behind. That can be really difficult for moms. And then there's the potential for injury from the delivery. That's mainly going to be related to something called shoulder dystocia. And what happens is that the baby's belly and chest are so much bigger than the baby's head that on the way out, the baby sort of gets stuck. It's a tight fit. Now, most babies that have this particular complication don't have diabetes. However, we do know that if your baby grows bigger in the area of the chest and belly as opposed to the rest of the pieces and parts related to high blood sugar, that is a risk. And then lifelong. So there is actually an increased risk for obesity and diabetes, both in childhood and in adulthood, for babies that were in utero from mom's gestational diabetes or diabetes in general. All right, it's finally over. We can celebrate. Or is it? Well, you're done with the pregnancy. Congratulations. Now you're going to have to do a 2-hour glucose challenge test at about 6 to 12 weeks postpartum. Why do we do this? Well, most women are going to resolve and they're going to go back to normal blood sugars after delivery, but about a third of them will actually still have blood sugar elevations. Up to 70% of women who've had a diagnosis of gestational diabetes will develop type 2 diabetes in their lifetime at some point. So women with gestational diabetes, they have a 7 times increased risk to have type 2 diabetes compared to women who've not ever had gestational diabetes. So what we want to do is we also want to identify women who have had gestational diabetes and may have resolved after delivery so that they know to follow with their primary care provider and get tested for type 2 diabetes about 1 to 3 years, every 1 to 3 years. You want to capture it as quickly as you can if you're going to develop it so that you can develop better habits and if necessary, get on medications necessary to control the blood sugars and preserve the function of your kidneys and your heart and your eyes. There is an increased risk for gestational diabetes in another pregnancy as well. And your doctors will address that likely by doing early screening and early testing in another pregnancy. All right, so we've heard what is gestational diabetes? What do we have to do if we get gestational diabetes? So the next question is, well, how do I reduce the risk of getting gestational diabetes? I don't want that. I don't blame you. Before you get pregnant, the key is before you get pregnant, you need to have healthy eating habits. Eating healthy foods. You need to try to maintain or obtain a normal BMI. And an active lifestyle is always going to be a good idea, but especially in preparation for pregnancy. And that again is going to be about 30 minutes of moderate activity a day. Lifestyle changes or medications to maximize control of cholesterol and triglycerides can also be important. So here's a little light reading if you happen to want more or more specific information about gestational diabetes and pregnancy, or even pre-gestational diabetes, which we didn't address specifically today. You can either get onto the ACOG website, SMFM website also has information, and two particular practice bulletins that you can access on ACOG's website address gestational diabetes as well as pre-gestational diabetes. And I know it sort of seemed like that was a little rapid, but I wanted to stick specifically to gestational diabetes, and I'm happy to answer any questions.
Thank you so much, Allison. That was amazing and so informative. I opened up the chat and just said if anybody, but I have a bunch of questions that people have sent in before ahead of time. So somebody asked about, they said that one of their friends was diagnosed with gestational diabetes, and they went to see a nutritionist, and they were surprised that the nutritionist told them to actually eat carbs. Can you a little bit speak about that?
Sure. So it's one of those other myths that people believe that, oh my gosh, I have gestational diabetes and now I can't have any carbs, I can't have any sweets. Goes along with that idea that I can't be diagnosed with gestational diabetes because my baby showers next week and I'm not going to get to eat my own cake. That's not at all true. It's moderation. They will instruct you if you have a diagnosis of gestational diabetes or pre-existing diabetes. In pregnancy, we want you to get the right number of calories, and you get these from various ways. You get that from fats, you get that from carbohydrates, you get that from protein. It's a balance of all of that throughout the day at each meal that will allow you to maintain normal sugars.
Thank you. That's so helpful. I know too, from my patients, sometimes they'll say, oh, the nutritionist is telling me to eat actually more than I'm used to eating. Have you heard that before?
Yes, I hear it all the time. So especially when you are first diagnosed with gestational diabetes and they give you a list of these things that you should eat and how much you should eat for each meal. That's when we really start to sit down and figure out that in general, women are probably pretty busy. We don't eat that much, at least at each meal. We tend to eat things on the run, maybe early in the morning. Sometimes we don't even have breakfast. And at lunch, we just grab something. And then when we sit down at dinner, that's when we really are starving, basically, and we eat a lot. And we eat sometimes the wrong stuff. So what we really need to do when we have gestational diabetes or diabetes in pregnancy is we need to spread all of that out. What we're trying to do is maintain normal blood sugars throughout the day. If pregnant women do not eat and they don't eat regularly, what ends up happening is they have a greater risk to go into ketosis. And that means that your body's not getting the sugar, the protein, the carbohydrates that it actually needs at that moment. So it's going to start breaking down those that are stored in your body. That's not what we want. We want moms to be eating throughout the day, and that way they will maintain normal blood sugar in that way. But at first, it's very common to feel like, I can't eat all of this. By the end of the pregnancy, you'll want all of that. Belly will be big enough to push up on your stomach, and you'll still say, I don't think I can eat all of this, but try to do your best so that we can maintain blood sugars in normal range throughout the day.
Does gestational diabetes increase the risk of shoulder dystocia more than if they just think that you have macrosomia without gestational diagnosis?
So from the standpoint of whether it increases the risk more or not, that's really somewhat difficult to say, but we do assume that if a mom has diabetes and a macroscomic infant, that we may have a further risk for difficult delivery, and shoulder dystocia is part of that process. So as a result, we make the recommendation that if you do have a macrosomic infant and you do have diabetes, that we consider doing cesarean section. The reason why women, specifically with diabetes or high blood sugar and a macrosomic infant, are potentially at a greater risk for something like a shoulder dystocia is going back to how the baby will put on its weight and size in response to the elevated blood sugars that mom passes over the placenta. So you may have a baby that is 10 pounds and you're not diabetic, and the baby's just big on every piece and part we measure. So baby has long femur bones, baby has a larger head, baby has a larger belly. That's okay. That baby's coming out symmetrically large, probably meant to be that big. However, when you have corrected high blood sugar through the pregnancy, the baby's head measures and leg measures, those are going to stay pretty standard for what was intended for the baby. Instead, what you start to see is that that baby's going to actually become a 9-pound baby because it will put on fat in the chest and belly region. So when we're measuring these babies, then what we see is that the baby's belly measure is significantly bigger than it should be and significantly bigger than the head and legs. That is called asymmetric macrosomia, and that lends itself to a greater risk of the baby having a shoulder dystocia or a more traumatic delivery.
Okay, that makes sense. As far as, I know you touched on it a little bit, but one of the questions somebody wrote in, and then I know I get it all the time. A lot of people don't know that things that happen during your pregnancy can actually affect your overall health care. So can you, I have a patient here that says that she had gestational diabetes, and then she was really upset because she went for her postpartum testing and they wanted to test her again for gestational diabetes. And she just kind of wrote a long thing about being confused about what that is. Can you talk a little bit about that?
Right. So that goes back to that 2-hour test that we talked about in the postpartum period. So the vast majority, 2/3 of moms that have gestational diabetes in pregnancy, when they're retested to see after they have got all those hormones from the placenta out of their system, if they go back to having normal blood sugars when challenged with that sweet stuff, 2/3 will actually go back to normal. But 1/3 of those moms will persist. They'll continue to have high blood sugars. Those may be moms that were actually diabetic to start with. But again, go back to the fact that we are not very good at taking ourselves to the doctor. We'll take our kids to the doctor. We'll make our partners go to the doctor, but we don't. So oftentimes moms will enter pregnancy and they have no idea that they have this going on beforehand. So by doing the testing afterwards, they're not really testing for gestational diabetes. What they're looking for is they're looking for whether or not you have some element of insulin resistance or inability to break down blood sugars the way that you should. It probably was that way beforehand, and now we're just going to confirm that. We want to make sure that these moms are not lost in shuffle, basically. After you have a baby, go right back again to what I said about how moms don't take care of themselves as well as they should. Your focus after you come home with a baby is on the baby. Your focus may be on the rest of your family, acclimating to having a new baby at home. And honestly, your focus is also probably on finding 10 minutes to shut your eyes with nobody saying mommy. So this is an effort to make sure that moms get the appropriate follow-up that they need so that their health going forward can be maximized. If you have still high blood sugars after delivery and it has gone away after the placental hormones that we blame for gestational diabetes, then we want your primary care doctor to be jumping all over that so that you can stay healthy, because you've got to raise this baby. And so we got to make sure that you're healthy to do that.
And thank you so much. And then another question that just came in via email. Someone was saying that they had a friend who had gestational diabetes and the baby was born at 40 weeks and everything was going great. And the baby ended up in the NICU because of sugars. So they want to know if diabetes, gestational diabetes, is that something that passes to the baby or why do they end up in the NICU?
Good question. So gestational diabetes and diabetes itself doesn't pass from the mom to the baby. Now, remember, we did say that having had that diagnosis with the baby in utero, that baby will be at risk for diabetes in its lifetime. But part of that is not just going to be because you had diabetes in pregnancy. Part of that's because the baby's related to you, and you may very well have somebody in your family that had diabetes as well, which increases the risk. But specifically with the baby, yes, when we have elevated blood sugars that we don't get controlled the whole way through the pregnancy. Remember, we talked about that the baby's pancreas is going to make a bunch of insulin because it's going to break down the blood sugar that you pass across. Well, when the baby comes out, sometimes these babies are struggling because they no longer have your blood sugar, but they've still got their insulin. And it takes a little bit of time for the baby's bodies to go, oh, wait a minute, I'm not getting mom's blood sugar anymore, and start to slow down how much of the insulin they make. That can make babies pretty sick. And sometimes these babies do end up in the NICU. And that's really difficult. It's one of the things that OBGYNs work really hard to prevent by making sure that moms keep tight blood sugar control. But sometimes babies do come out and drop their blood sugar.
Okay. And usually the stay in NICU isn't that long, or does that, I mean, is that something that's going to be a long-term problem?
That varies. For the most part, it's not a long time. For the most part, it's a matter of days till the baby's body sort of says, okay, I get it. I'm not getting all this the high blood sugar from mom anymore. And it'll kind of acclimate to normal. Some babies, however, that are exposed to high blood sugars for long periods of time in the pregnancy can be quite sick, and they can end up in the NICU for a bit longer than we want, unfortunately. For the most part, that's going to be moms that have poorly controlled pre-existing diabetes rather than gestational. But the same idea applies across the board. The tighter we can keep blood sugars that go across the baby, the better chance we have of preventing the babies from having to go to the NICU or having any difficulty after.
Thanks so much. And then the last question, so you spoke about this, but the last question is from a mom who just found out she's pregnant. And she says that she had diabetes in her last, or gestational diabetes in her last pregnancy. And she wants to know if there's anything she can do to change that this pregnancy, or if there's anything that she actually, I think this is her first time delivering here in this area, but she said that she delivered outside. And so she wants to know kind of what to tell her OB provider and to see if there's anything she could prevent it from happening in the future.
So if she's pregnant right now, and if she's not yet taken she'll probably have an early test if she had gestational diabetes before. But assuming that is a negative test, in trying to reduce your risks of having the test in the third trimester turn positive for gestational diabetes, you can do a lot of those things that we would be asking you to do to control your blood sugars with a diagnosis. So this would be a good time to make sure that you're eating healthy, making sure that you're eating healthy meals throughout the day, and potentially to begin a moderate exercise schedule with 30 minutes every day, if you can, in the week. That can go a long way toward improving your overall health, but also to combating the insulin resistance that may be building as a result of the placental hormones. They'll still test you. You still carry that unmodifiable risk of having had gestational diabetes in the past pregnancy, but all of those other efforts with diet and exercise now may improve the chances of you not turning positive this time. When I say diet, though, remember, eat healthy and eat each meal. Do not try to actually diet to lose weight. You're just making sure that you're eating a well-portioned, moderate diet.
Yeah, that's so important. Okay, thanks so much, Allison. That was wonderful. We have a couple more minutes. I just wanted to make sure, Jennifer, Katie, you don't have any pending questions, and if not, we will sign off from there. I don't see any. Oh, do we have any? Yes. Oh, good job. Everybody in the room is applauding you. Oh, how about amniotic fluid in gestational diabetes?
So amniotic fluid and gestational diabetes, that is something that we do need to watch. And that is why we would be doing the serial growth ultrasounds during the pregnancy, make sure baby's growth is also on track. So when you have uncorrected elevated high blood sugar going to the baby, one of the effects is that the baby will get chubby in the belly, more so than the other parts of the baby. But with having the exposure to the high blood sugar, the baby's actually going to pee more, urinate more. And I know it's gross, but we all did it. The amniotic fluid is urine. We all swam in it and swallowed it. It's kind of nasty, but we all did it. So if you have a baby that is getting elevated blood sugar exposure, then that makes the baby pee. So think about people who may have known that diagnosed diabetes that in childhood or early adulthood, where one of those symptoms is that they're thirsty all the time and that they have to pee all the time. That is the effect of the high blood sugar. It makes you need to go to the bathroom all the time. So that's what the baby's doing in there. And as a result, it doesn't cycle through the fluid as fast as as it's putting it out, and you get too much around the baby. So that also comes along with having a bigger baby pee more. So if you have that build up around the baby, then several things can happen that we worry about. One is mom's really uncomfortable when that happens. For the most part, we don't have to do anything crazy like go in there and take fluid out before the baby's born, but it can be really uncomfortable for moms to have extra fluid because you feel like you're way more pregnant than you really are. And then you're also going to have people come up to you and ask you, are you sure there aren't twins in there? Which is going to really help. So
I hate that. Should nobody say ever.
Exactly. Or they say, are you sure you're going to make it? So that's never fun. So that's number one. But number two, and probably more importantly, is that is going to make your body think you are more pregnant than you really are. It's going to over distend your uterus or make it spread out more. And then your body is saying, well, you know what? Okay, I'm closer than I thought I was to term. Let's get to getting labor on. And you start having contractions. So even if they don't immediately lead to labor, they can be very concerning for moms and they can be uncomfortable as well. But it can increase your risk that you can go into labor early, or you can break your bladder. It gets so big and it just breaks at some point. And then that can lead to complications where you need to be delivered. So
Allison, I'm so sorry. This is so great. We're just running out of time, and I just wanted to say one more thank you before we do. But if you guys have any questions, you can always email us, and we can try and siphon them to Dr. Dorica. Thank you so much for coming on.
Thanks.
Bye, everyone.